Hi, welcome to EDSC 541. My name is Professor Bobo, and this is week 4. So welcome to week 4. Just a quick overview of our assignments for the week. This week, you have just 2 discussion boards, and then you also have your readings from chapters 7 and 8, and then you will have videos for this week. This week, I'll be talking about chapters 7 and 8, and they begin discussing schizophrenia and mood disorders. So I'll talk a little bit about how we can assist, and I'll have a case study as far as how we can help an individual who is presenting depression and ADHD, and we'll go over a diagnosis that, again, as I've been stating, as school counselors, we would not be responsible for getting that diagnosis, but I'll go over the steps as if we start seeing some symptoms, some ideas that we would give that parent as to how to assist them in getting the additional support. And then once we get a diagnosis, how to support that student using some of the theories that we know in that area, okay? So again, we're going to be talking about mood disorders and suicide also. And we're also going to be talking about schizophrenia. So mood disorders are defining features that are extreme of emotion or affect. And there are other symptoms or co-occurring disorders. There are 2 key mood disorders that the DSM highlights, and that's depression, feelings of extraordinary sadness and dejection, and then mania. And this mania is an intense, unrealistic feelings of excitement and or euphoria. There are 2 types of mood disorders, unipolar depressive disorders, which is only one depressive episode, or bipolar depressive disorders where there's manic and depressive episode. Okay, so some prevalence behind mood disorders. There are lifetime prevalency of major depressive disorders is about 17%. 12-month prevalence ratings are nearly 7% and about twice as common in women than in men. And over a lifetime, prevalence for bipolar is at 1%. Some demographic differences in the United States. Native Americans have had a relatively high rate of depression. African Americans have a relatively low rate of depression, and US rates of polar depressive inversely relate to socioeconomic status. Some major depressive disorder mood, it is MDD. It is a major depressive episode without having mania, hypomania, or mixed episodes. Relapses can occur, and they can begin at any point in our lifespan. Incidents can increase during adolescent time, and it may include additional symptoms. Some specifiers. There are things that with melancholy features, and these are 3 of the following: early morning awakening, depression worsens in the morning. It's marked by a psychomotor agitation and loss of appetite or weight, excessive guilt, and difference in depressive moods. With psychotic features, it could include delusions and hallucination. Feelings of guilt and worthlessness are very common with psychotic features. With atypical features, the mood reactivity, it brightens to positive effects. 2 or 3 of the following symptoms can occur: weight gain or an increase in appetite, hypersomnia, leaden paralysis, arms and legs feeling heavy as lead, and being acutely sensitive to impersonal rejection. With catatonic features, a range of psychomotor symptoms from motoric inability to extensive psychomotor activity, as well as mutism and rigidity. And with seasonal patterns, at least 2 or more episodes in the past 2 years that have occurred at the same time, usually with fall and winter, and full remission at the same time, usually in spring and summer, and no other seasonal episodes in the same 2-year span. Persistent depressive disorder is mild to moderate. Persistent depressive moods most of the day for at least 2 years. Intermittent normal moods occur briefly, and there's a lifetime prevalence of 2.5 to 6%. And the average duration of this depressive disorder is about 4 to 5 years. Other forms of depression, bereavement-triggered depression, and postpartum depression. So there are some causal factors of mood disorders. There are biological and psychological. The biological factors can include the genetics, altered neurotransmitter activity, hormone and immune system regulation abnormalities, physical and neural anatomical influences, sleep and biological rhythms, and sex differences. Some psychological causal factors, stressful life events. They can be independent versus dependent. They can be vulnerable in response to stress. They can be risk-related vulnerability factors, such as personality and cognitive diseases, and early adversity. Some theorists that spent a lot of time with the psychological causing factors are Freud and the behaviorist and the cognitive model. So Beck's cognitive model of depression usually is experienced early, and then formation of the dysfunctional beliefs, and then there's a critical incident, and then beliefs are activated, and then negative automatic thoughts occur, and then symptoms of depression happen. They can be behavioral, motivational, affective, cognitive, or somatic. So there's a negative connotative triad that occurs with this in his model, in Beck's model. And it is the self, I'm ugly, worthless, a failure, the world, no one loves me, and the future, it's all hopeless because things will always be this way. The theories help to reformulate helplessness theory. And the hopelessness theory helps to organize that the world isn't hopeless, and then excessive rumination. So interpersonal skills that affect the depression is lack of social support or social skills, hostility and rejection from others, and marital dissatisfaction. When we're talking about bipolar, it is distinguished from unipolar disorders by the presence of a mania or hypomania episodes. Cystic mood swings is another disorder where it happens less severe than those of bipolar disorders. The symptoms are presented for at least 2 years, and they're lacking several symptoms and psychotic features of the bipolar disorder. With bipolar, there's bipolar 1 and bipolar 2. Bipolar 1 includes at least one manic or mixed episode, and bipolar 2 includes hypomania episodes, but not full-blown mania or mixed episodes. Bipolar 1 and 2 seem to occur more equally in males and females. It usually starts in adolescence or young adults. The average age of onset is 18 to 22, and it's about 3 times as many days are depressed as in the manic or hypomanic. So there is a manic depressive spectrum. So when the person is going through mania, you have your normal mood variation, then you have your cystic thymic personality, and then you have your cystic thymic disorder, then you have bipolar, then you have unipolar mania, and then bipolar 1. So that's starting from normal all the way to occurring frequently. So some of the causal factors for bipolar is it's hereditary. The norepinephrine, serotonin, and dopamine are not working right, and there's abnormalities in the transportation of ions across the neural membrane. Sometimes the cortisol levels are high, shifting patterns of blood flow to the prefrontal cortex, and disturbances in the biological rhythm. Some psychological causal factors, stressful life events, personality variabilities, low social support, and pessimistic attribution style. Some social factors affecting unipolar and bipolar disorder. Symptoms of mood disorder can differ widely across cultures and demographics groups, and prevalence of mood disorder can also differ across cultures. Forms of depression does vary with our different cultures. The Western culture, the psychological symptoms, we look at more at that. And then the non-Western cultures, they look at the physical symptoms. So treatments and outcomes, pharmacological therapy, which is medication to help that. Alternative biological treatments, we'll talk a little bit about that, and psychotherapy, which is what we're responsible for. Some medicines that are usually prescribed with these disorders: antidepressants, mood stabilizing drugs, antipsychotic drugs, and these help to treat that mood disorder. Lithium is a common mood stabilizer for bipolar. Some alternative biological treatments that have been used is electroconvulsive therapy, transcranial magnetic stimulation, deep brain stimulation, and bright light therapy. Some psychotherapies, cognitive behavioral therapy, we'll talk more about that. Behavioral activation therapy, interpersonal therapy, and family and marital therapy. So suicide is often, risk factors are often discussed with these particular mood disorders. Suicide risk has a significant factor in all types of depression. Suicide is now the 10th leading cause of the death in the world. So I wanted to share with you our suicide prevention program. Our suicide risk assessment factor. All right, so this is Hawthorne School District's suicide prevention policy, intervention, and assessment. So every year, our school counselors are responsible for training the students, and we are the ones that are also responsible for looking over the policy and procedure annually and updating it according to our needs. So our school and staff responsibilities, we have two primary people that are responsible for doing the suicide risk assessment based on our training and our credentials, and that is the school counselor and the school psychologist. If the student is in imminent danger, then we have to call 911, has access to a gun, is on a rooftop, or other unsafe conditions. We're never to leave the student unsupervised. This is what we discuss throughout our training. The additional information for our administrators. A lot of times we get new administrators or new psychologists or counselors, and they're not familiar with this policy and procedure. So it is the counselor and the psychologist will do a formal risk assessment. And then if someone is not available, as you can see, many times people are off that day at a training session or somewhere not to be found, then it is the responsibility of the administrator to find one of those, either both or one, to replace the person that is not available at the site. If we need to use the psychiatric mobile response team, the PMRT, for us in our region, we use the Hawthorne Police Department, depending on circumstances. We used to have a school resource officer. Unfortunately, we don't have that at this time. And the PMRT wasn't as available in the past. So we have these different organizations that have an ebb and a flow. You know, sometimes you're able to reach them and then sometimes you're not. And then under the normal circumstances, the team meets. The administrator is part of the team. The administrator does all the note taking. So what we do is I interview the student alone or in front of the administrator. Then the psychologist will interview the student alone or in front of the administrator, but I might not be present. The purpose of that is so that the student, if they lied the first time, they might be more honest the second time. Even if you have a rapport with the student, they may not want to disappoint you. So these are things that you would want to take into consideration. Then the team meets and then they determine whether it is low, medium, or high risk. Whatever the case may be, the parent should always be notified. So at an elementary setting, we contact the parent, bring the parent in, discuss the information with the parent, give the risk assessment, determine whether the child can stay at school or not, and then go ahead and give the parent materials and information that they may need in order to watch the student and make sure that the parents are aware that they're not to leave the student alone. Make sure that the student doesn't have access to any guns or weapons or any way of hanging themselves or causing additional harm to themselves. And then we also refer to our mental health agencies. Now, this is tricky because if your mental health agency is full, this is difficult. Hopefully you work with many outside agencies so that you can put a call into someone. You give the parent the emergency response number so that they have something upon returning home. Okay. Okay, we also have, I talked briefly about self-injury, which is, causing self-harm. So this follows under that same category of the risk assessment. So we want to make sure that people are aware of that. And we want to make sure that the student is receiving therapy for that self-harm. All right. See what else. So chapter 8 begins to discuss the schizophrenia and other psychotic disorders. And schizophrenia is psychosis. It's a significant loss of contact with reality, and it's the hallmark of schizophrenia. So the first clinician description appeared in 1810, and then it was Eugene Bueller who introduced the term schizophrenia in 1911. So it has a lifetime prevalence of 1%. The age of a father over 50 is the person who's most often at risk. Parents, onsets between 18 and 30, and gender. Some hallmark symptoms of schizophrenia is delusion, hallucination, disorganized speech and behavior. The delusions include erroneous beliefs, fixed and firmly held despite clear contradictory evidence, disturbance in the content of thought. Some examples are external agent controlled thoughts, neutral environment, and events that have personal relevance. Hallucinations include sensory experiences. They seem real but occur in absence of any external stimuli. They can occur in any sensory modality. And disorganized speech, failure to make sense despite conforming to systematic or syntax rules of speech, and disturbances in forms of not of content, but of thought. Disorganized behavior, impairment of goal-directed activity. It occurs in areas of daily function. It can include catatonia and catatonia stupor. It can have positive and negative symptoms, absence or deficit of normal present behaviors, poor clinical outcomes. It could be excessive or distortion in normal repertoire of behavior and experiences, and disorganized thoughts. There are subtypes of schizophrenia: paranoid schizophrenia, disorganized schizophrenia, and catatonic schizophrenia. Some other psychotic disorders that are discussed in the DSM-5 are the schizoaffective disorder. It's features of schizophrenia and severe mood disorder. Delusional disorder is delusional beliefs with otherwise normal behavior. Schizophrenia informed disorder, which is schizophrenia-like psychosis that lasts at least 1 month, but less than 6 months. And then brief psychotic disorder, which is a sudden onset of psychotic symptoms or disorganized speech or catatonic behavior. It can have genetic and biological factors. It can be a, let's see what else. Some causes have been viral infections, early nutritional deficiencies and maternal stress, pregnancies, and birth complications. Some neurodevelopmental perspectives. Some people have said that people have had onsets of schizophrenia from brain lesions that lie dormant until normal development changes occur. Changes can expose problems resulting from the brain's abnormality. It could be a developmental precursor, which may include a variety of abnormalities. Neurocognitive deficits found in people with schizophrenia, their attentional and working memory have deficits, and their eye tracking is dysfunctional. Some other structural and functional brain or abnormalities that occur in schizophrenia: impaired social cognition, difficulty recognizing emotion in facial expression or speeches, loss of brain volume, enlarged brain ventricles in some patients, and gray matter loss, and then white matter, reduced volume and impairment. It could also include disruptive brain functioning, less efficient at challenging tasks, temporal and front lobal impairments, compromised architects, so difficulty handling normal stress levels, disruptive brain development in adolescence. It's linked to like a head injury of some sort, or a neurochemistry, which is dopamine and glutamate. So some psychosocial and cultural aspects that can affect schizophrenia: families and relapses, urban living, immigration, and cannabis abuse. So the treatments and outcome for schizophrenia, the anti-drugs were more positive beginning in the 1950s. 15 to 20 years of outcome and long-term institutional rates were more positive in the past. With pharmacological approaches, the first generational antipsychotics and second generation antipsychotics and so had some side effects, but they were more effective than harmful. The psychosocial approaches were family therapy, case management, social skills training, cognitive remediation, cognitive behavioral therapy, CBT, and other forms of individual treatment. So some recovery rates are not improving with schizophrenia, and staying on the antipsychotic medications don't provide long-term benefits for patients. And there's poor clinical outcomes of medicated patients to the continued use of the antipsychotic drug. So that's the meat of the information for the two chapters, chapter 8 and 9. So now we're going to go over a case study, and I'm going to share my screen with you again. And this case study, I'm going to read it to you and go over it with you. And then we're going to talk about how we would contribute and assist with this particular case study. Okay, so Joey is 12 years old, overweight male, and he was sent to the clinic with his head down, kicking the desk with his leg repeatedly, refusing to look up for the first 10 minutes of the session. His mother was outside waiting eagerly for him to be seen. Prior to the meeting with Joey, she told the social worker that she was really worried about him, and that's why she brought him in. She complained of his constant angry outbursts, and she said that Joey's 14-year-old sister couldn't handle him anymore. Since her divorce became final about a year ago, Joey had become increasingly difficult to manage. Joey's mother said that he was never an easy child and was always had negative thoughts about things, but the divorce seemed to increase the negativity. So we see right there that it was an event that increased the negativity. Joey's father didn't visit because, did visit, but said that he didn't stay long because he didn't know how to deal with Joey and his temper tantrums. He stated that his teachers were also complaining of his temper tantrums in the classroom. He was not doing well in school and his grades were continuing to decline. In addition, Joey, mother said that she recently got a phone call from one of his only friends, and that the friend was, that Joey was no longer welcome in the home. And this was because there was an argument between two boys, and Joey ripped the control from one of the visitors and threw it on the ground and stomped on it until it broke into pieces. And that the friend's mother said that she didn't want that type of behavior around her children. So at the beginning of the interview, Joey wouldn't speak. And after a minute of silence, the practitioner explained that looking at a person who was speaking was a way of showing courtesy and that he was listening. Joey eventually lifted his head. He stopped kicking the desk and he began to talk. Joey explained that he really didn't want to be around people and that he didn't understand them and that he would get so frustrated. He said that he may not look like he's listening, but he hears every word. He just doesn't want to respond. He reported that people constantly pick on him and that he did not want to be angry, but he would get so frustrated with them and the demands they put on him. When asked what demands he was referring to, he said in a defiant tone to mimic the person talking, turn off the radio, turn off the game, do your homework, sit in your chair, and look at me and said, "Stop kicking my desk." When he was reminded that he had not been asked to stop kicking the desk, he quickly said, "You were thinking it. I just beat you to the punch." He stated that he had no friends. He hates his family. He was always so sad and empty, and that made him even angrier. When he discussed his anger, he said it was constant, and the only time he didn't feel it was a period of time when he met his best friend. He described their friendship as good until they got into a fight over the video game. His friend told him he couldn't play it, and he had to go home because his mother said dinner was ready. When he gets angry sometime, he eats. Since his appetite has increased, he's gained weight. He sleeps excessively. He feels tired most of the time, and he wants to avoid people as much as possible. He reports that he has difficulty concentrating, is often bored, and has little interest in school or friends. Although Joey doesn't admit directly to suicidal thoughts, he did state that openly that he doesn't like himself or others, and many times wish he were dead. His mother and sister confirmed Joey's self-statements, and 15 minutes into the session, Joey excused himself for a drink of water and took a bathroom break for 10 minutes. When interviewing his mother, she explained that since the divorce about a year ago, he has become harder to control, and each week he's had several tantrums over the slightest thing. She said that the one outburst just yesterday was related to the breakfast waffle. He was so angry that it burnt in the toaster that he ripped the cord out of the wall. And when she tried to discipline him, he threw the waffle on the floor, stomped on it with his foot. And she explained that in the past year, he had been cruel to his older sister as she was not helping the matter. When he gets upset, she calls him psycho, and then his anger escalates even further. His mother stated that during the past year, his anger outbursts have been increasing as she knows his depression. He's depressed, but he won't admit it. When she tries to talk to him, he just gets angry. She says he is just angry all the time. She worries about his irritability, depression, disruptive behaviors, and temper tantrums, and his behavior scares her. His behavior is unexpected and reckless. And to support this statement, she describes several incidents. The first occurred when she told her son that she could not take him to the park because she had to go to the store to get groceries. He was so angry, he jumped on the back of her vehicle as she was pulling out of the driveway. Another incident occurred when he was caught walking on the ledge of their house outside the window, the two stories high. When she questioned, she said his reply was, "I just needed some fresh air." She explained that at times she feels he's going to be okay, and he seems to be enjoying a task. However, irritability surfaces quickly, and she also stated that he can't sleep. So over the past 2 years, the mother reported multiple episodes and of his being unable to complete tasks because he was easily distracted. And when he asked to do something, he was completing a task he had selected. He refused to stop, and what he was doing and getting angry at the interruption. His mother reported that over the past year, he started talking on her cell phone without permission. With the phone, he would call total strangers, which resulted in using up her minutes and getting some angry return calls. She said that there had been so many incidents where he's had a temper outburst when things didn't go his way. She could write a book. 6 months ago, the behaviors resulted in arrest on a simple assault for chasing his mother and sister around the house with a fork. His family members have lost patience with his habitual moaning and complaining, as well as his angry outbursts related to the events that other family members consider trivial matters. His sister and mother says he will argue, make verbal threats, and show rage for hours over simple things like not getting a glass of milk, sandwich, television program when he wants it. 2 weeks ago, he got on a city bus with his sister, put on his headphones, and listened to the music at top volume. When he was asked to turn it down, he became more irritable, nasty, and cruel to the passengers. This resulted in another arrest where he was placed in an inpatient mental health facility for several days. Joey's mother said she will now involve the police in transporting her son to the hospital or residential treatment when there is a physical threat or it becomes irrational. It's obvious his mother is very frustrated and would prefer not to take him home with her unless we get help and help him control his behaviors. She would prefer that he not take medication for the outburst, and Joey agrees. Both state that the last time he took an antidepressant, the symptoms appeared worse. They didn't know the name of the medication because he only took it for a short time. So now that is our case study. And now I would like to tell you, okay, so after the case study, which they took him to an outside agency, and that is where the outside agency has now begun to assist with diagnosing Joey. So our role as a school counselors, we would have seen some of these types of behaviors. I think some of the behaviors that the school began to observe were that he's low academically, obviously, because he's not focusing and he's distracted. He does hear things, but then he gets so angry at certain things when he can't do what he wants to do, he's missing most of the information. Possibly he's not interested in school. So again, that would affect the learning. And so you have two areas. So you have a mother who is afraid of her own child, and then you also have him being low academically. So our responsibility as a school counselor would be to refer him to an outside agency. We didn't have to do that because the arrest required that. So she was already at a mental health facility getting a diagnosis. So while we awaited that diagnosis, we wanted to try certain things to help him, try some calming factors. We would definitely want to watch the depression and the suicidal thoughts. And again, this is something that we would look at and assess on a daily basis. We might even do a safety plan for him to support him while he is in school. So he comes back after several meetings with the therapist. They finally give him a diagnosis, and the diagnosis is disruptive mood dysregulation disorder, DMDDS, and it has 11 specific criteria ranging from A to K that has to be met. The core feature is irritability that is persistent for at least a year and maintains a severe and continuous course that is not related to a developmental phase. The behaviors are not consistent with the precipitating events and involve either verbal or behavioral manifestations towards people or property. Temper outbursts must be continuous, occurring at least 3 times over a 7-day period, and other criteria are documented, okay? So signs and symptoms that were noted in the assessment process: agitated depression, sleep difficulty, distractibility, verbal outbursts, rage, physical outbursts, destruction to people and their property, and psychomotor agitation, impulsivity. So the goals, okay, so now the goals are written for the therapist, and we are there to support the therapist. The therapist will talk to us, and we would sign a release of information, and we would share this because obviously Joey might exhibit some of these symptoms and signs at school: destruction of trying to cause harm to others, as well as destruction of property. So the goals would be to reduce uncontrollable anger outbursts, return to normal activity levels and increase good judgment, reduce agitation and impulsive behaviors, and increase sensitivity to consequences of behaviors, cope with underlying feelings of low self-esteem and fears of rejection or abandonment, increase control behaviors, and achieve a more stable mood, and develop more deliberate speech and thought process. Address feelings of anger, depression, and develop alternative ways of coping. So those are the goals that how we would do these. We would kind of take one or two and try to assist. Like definitely we wanted the uncontrollable anger outbursts to return to normal activity levels. That's going to help him perform better in school. Reduce the agitation and impulsive, maybe bring it, kind of giving him a timeout place, a timeout room so that he can have that. We would have therapy at school, meeting with a school counselor to go over consequences and behaviors and getting a better reaction with that. Also, dealing with the low self-esteem, that would be our responsibility, rejection or abandonment, and having more deliberate speech and thought process, okay? So some objectives, okay? As I said, we're gonna cooperate with the psychiatric evaluation and participate in treatment as warranted. That's for the student. And so we would want to support that. So we want to double check with mom, make sure mom is, she's not because she's overwhelmed. She's a single parent. So, and then she only has the 14-year-old daughter who's assisting her, who also is fed up with his behavior. So we want to make sure that they don't just stop treatment. I mean, they have a diagnosis, they don't want medication. So we have to make sure that they're getting the therapy that they need in order to be successful. We want to reduce those impulsive behaviors. We want to express self and desires more realistically. We want to be able to sit calmly for 30 minutes without agitation or distractibility. We want to be able to help them develop and speak more slowly and maintain focus on one subject at a time, and identify and process feelings related to anger outbursts and thoughts related to underlying depression. So some interventions that are in place for the student. Not all of these would be our responsibility, but I'll touch on them to tell you. So arranging for the psychiatric evaluation to assist with angry behaviors, definitely we're going to do that. And like I said, we would try to do it without medication. And as school counselors, we don't recommend medication, but at some point, there might need to have a conversation about it. Discuss the potentials for medication to assist with the depression. Request a no harm, no risk safety plan to be put in place. I've discussed that already, that we will put a safety plan in place for him with his at-risk behaviors. Behavioral rehearsal and cognitive behavioral strategies to recognize triggers and consequences of the behavior. So that would be something that we will work with him on at school as we see these behaviors being exhibited in the classroom, on the campus, with others. We want to do that. We're going to help the client problem solve using behavioral rehearsal and individual support therapy and psychotherapy to reinforce more realistic self-statements. We're going to reinforce clients' increased control over his energy and help the client set attainable goals and limits on his agitation and distractibility. We noticed that his appetite was increasing, so maybe putting him in some type of activity, trying to find something that he enjoys doing that is more active so that we can address the initial weight gain and then the feelings of success. We want that as well. And then providing structure for the client's thought process and action by directing the course of the conversation and developing plans for the client's behavior. And then we're going to have in supportive therapy, helping the client to identify 2 reasons for his angry outbursts and problem solving other ways to address his frustration. So when we're working with Joey at the school, we want to, the following treatment modalities are suggested. So peer support group, family therapy, and family support group therapy. Now, of course, we aren't going to do the ones that we could help him with are the individual and peer support, and then the family therapy would be for the other therapists that he's seeing outside, okay? So cognitive therapy. these are the strategies that we would use. So cognitive therapy is most effective with students with depression. So we would help Joey identify cognitive distortions that support the development and maintenance of problematic thoughts and behaviors. As we read in the case study, he tends to say, nothing's right, everybody's angry, you were going to say that anyway. So we want to discuss those negative distortions and relate to expectations of the environment, self, future that contribute to the depression, okay? We're going to examine Joey's perceptions of the environment and activities that are seen as unsatisfying or unrealistic, identify dysfunctional patterns of thinking and behaving, that's REBT therapy, and guide Joey to evidence and logic that can test the validity of his dysfunctional thinking. So we're going to assist in the understanding the automatic thoughts that occur spontaneously and contribute to the distorted effect, like personalizing, the all or nothing attitude, mind reading, discounting negative. So these are all the things like, you know, the mom mentioned, if he can't have milk, then he goes around and destroys the house. We would see some of the same type of behaviors potentially at the school. At the school, we would say, okay, you have to put the computer away and we're moving on to the next thing. Well, if the next thing is not something that Joey wants to do, we're going to see these outbursts, we're going to see the destruction of behaviors. So we want to, you know, work with him on not the all or nothing. So maybe even giving him a timer to get him like, okay, we're almost done. You have about 10 more minutes. We're going to begin transitioning, you know, some other things. If this technique is not helpful or it doesn't work for Joey, help him to understand and explore other possibilities. Another thing is I statements. Instead of saying you, which we heard in the case study, we want him to say I feel and teach him the I statement so that he can take ownership of his feelings and kind of sit in those feelings a little bit and try to, you know, understand why they're happening, where they're coming from, and so on. So a problem-solving exercise would be a CBT exercise. And what we would do with Joey is like, okay, he was at his best friend's house. The best friend said that he had to stop playing. It was dinner time, but he destroyed the best friend's thing. He said that that was the happiest time of his life. So we want to like really get an understanding of what was the true problem there. Because he may be saying, oh, I just didn't want to, I wanted to play the game and my friend wouldn't let me play the game. No, what was the real problem, you know, at that moment? Was it the rejection? Was it that he had to go home and he liked being there? So we kind of want to kind of identify what the real problem was. And then brainstorming and evaluating solutions. So we want to, you know, help him, you know, take action like, okay, well, I can't play today. So what would have been a more positive outcome? Because the outcome that he got is he can't go back over his best friend's house. So now he has been, you know, not allowed to participate, you know, hang out with this person whom he's connected with. But a better solution would have been to say, okay, can you bring the game over to my house? Can we play at a different time? You know, brainstorming potential solutions that have a better outcome than the consequence that he had, and then taking action. Breaking down the problem into steps and then making it so that it's far more achievable when you see the problem and when you're trying to attack the solution of the problem. Some other possible therapies, social skills training, like we talked about earlier, how he should be acting in the different environments. When he's at a friend's house, when he's at school, when he's over here, what are the expectations in the other environmental areas? And relaxation and breathing exercises. He gets so worked up. So does he need to de-escalate first when he can't get something before moving on to the next activity, before breaking up something? Maybe we can, you know, get some fresh air, do some breathing exercises and some relaxation. And then cognitive restructuring, which is a behavioral therapy exercise designed to help people examine unhelpful thinking patterns and devise a new way of reacting to the problematic situation. So we want him in our individual therapy, we will be working with him on that, like cognitive restructuring. So now you're not able to go over to your best friend's house. Maybe we would help him with apologizing to the parent, maybe replacing the item, or helping the individual get another one, so that he can be given a second chance to return back to the home. And we wouldn't want him to do that prior to having more success, because the outbursts could occur. But and we wouldn't want the parent to ban him forever or not allow the child to come over ever again. Okay, in the peer support group therapy, so we would have peers who have anger issues, and what do? This helps them to feel normal, like I'm not the only one suffering from this. So they all kind of work through some of the things that they've done wrong, how it made them feel when they did something that was troublesome or embarrassing, and discussing medication also. Like maybe some people will tell them, well, I took the medication and I didn't like it at first, but now I notice I'm better, so just kind of helping them to understand a little bit about how the medication, it's about finding the right one and going over that. This type of group will help Joey gain a sense of perspective and his condition, and tangibly encourage him to link up with others who have common problems and give him a sense of hope. And when hope is conveyed, an individual can see that he's not alone or unique in experiencing this illness. So then the family would participate in family therapy. And this is something that's super important. We ask school counselors, we want to make sure that, because Joey doesn't get better if everyone at home still has certain attitudes that they that are a trigger for him, and that they keep calling, like if the sister keeps calling him psycho, or that we have to have training for that, because a lot of that expectation is that, oh, he's just going to get better, and he's going to improve, and that doesn't happen. So we have to work with the mom and the sister to formulate a therapeutic plan to resolve symptoms and restore and create an adaptive family function, build an alliance with Joey, and establish a positive working relationship between the client and the family. So we would help Joey's sister deal with Joey's behaviors and examine how she may be contributing to them in some of the ways with his behavioral outbursts, and kind of review some of the stressors. An event can happen to a family, and it can be affecting all three people in different ways. Okay, Joey's going through depression. The sister could be having a different affect. The mom could be having a different affect, and all of them together in that household is not helpful. Examine any objective and subjective burdens to the family and what they're experiencing, and observable aspects of his illness that they need to help in providing caregiving, and looking for criticism and emotional over-involvement of family members in the response of Joey's illness. So he has a diagnosis, and we don't need the extra family members saying, yeah, there's nothing wrong with him. He just needs this, or he just needs that. And we have those age-old saying, oh, he just needs his consequences or a punishment or something like that. He has this diagnosis for a reason. How long the diagnosis happens, depends. It depends on the success of the treatment. It depends on how long, depends on the supportiveness of the family and other family members. So we just need to eliminate all of those factors. And then we need to help redefine the nature of the family's difficulties, encourage recognition of each family's contributions to the discord, recognize and modify the communication patterns, rules, interaction patterns, increase reciprocity through a mutual exchange of privileges, and decrease the use of coercion and blaming, and increase cooperative problem solving, and increase each member's ability to express feelings clearly and directly, and to hear others accurately. And then the family would go to a family group therapy, And this atmosphere helps them to grow and change and discuss the importance of complying with the treatment strategies outlined and provide the family members with a feeling of security when discussing troublesome and embarrassing issues. So, you know, we want them to have a safe place to go and discuss what's happening in their household, because sometimes that could just be seen as embarrassing, like the phone call from the mother of the friend, like, oh, great, now you can't go over there. So just, you know, having a place like, it was embarrassing, how do I get past it? And how can I continue to support my son? All right, so those are the strategies that we would use as school counselors. Some of those things, as I pointed out, and going through the strategies, we would just support. So we would use them as they relate to our environment, which is the school environment. Obviously, the school environment, it has to do with the friends and the peers and relationships and self-esteem. So we're there to support that and give that encouraging environment. And change takes a lot, especially for family members. So we're the group that is aware. We are aware that change takes time, and that no matter how much evidence you have, how much empirical data you have, how much, you know, some people, it's just hard for them to accept what's happening. So it's important for us to understand that. All right, so this is our first case study of the class, and we'll should be our second one because we'll do one. We did one in week 3, and we'll continue to see how we, as school counselors, will support these diagnoses, or even how we may see some symptoms and refer out to get the additional support for the family. All right, thank you. Have a great week.